Good afternoon, everybody. I bring greetings from Sakra World Hospital, Bengaluru, where I work as a consultant pediatric anesthetist and also head the department of anesthesia. At the outset, my sincere thanks to all the organizers, especially Dr. Vandana Kulkarni, for giving me this opportunity to address all of you about a topic that is dear to me: assessment and management of acute pain in children. Over the course of the next 20 odd minutes, I would like to discuss about some myths that surround pediatric pain, which is probably making our pediatric pain management not as optimal as adult pain management, for instance. We will also look at what the consequences of not treating pain well in children are. We will look at various tools we have to assess pain across the spectrum of pediatrics. We will look at multimodal strategies for managing post-operative pain, and also finally a mention of patient-controlled or nurse-controlled analgesia in kids. Is it safe? And if yes, what is the recipe that we could use? About 1.5 million children have a surgery every year. And according to various numbers, something between 20 and 25% of these children, their pain is not managed as well. And about 1 in 5 of such children can end up in a chronic pain state. So the problem in front of us is quite real and of quite a high magnitude. Common things we have heard over the years are, oh, small babies don't even feel pain. Even if they feel pain, they probably don't remember it. This is not just in India, this is across all systems, actually. The other thing we hear are that kids are resilient, they're tough fighters, and a little bit of pain is almost character building, and it's not a big problem. And also that opioids are too strong for a child's pain. So we will look at these and aim to debunk them now. Especially the postgraduates listening to the talk will be surprised to know that up until 1985, there was virtually no acknowledgement that neonates even felt pain. So analgesia was not even considered important, whether on NICU or even during the operating procedures, because the feeling was that they don't perceive it, and even if they perceive, they don't remember it. It was an important paper by Anand et al. In 1985, so only about 35 years ago, that showed the presence of endocrine shock, and frankly, deaths were happening when children were being operated without anesthesia. And that is when more emphasis about neonatal anesthesia and neonatal pain started emerging. Now the evidence is very clear. Yiannakopoulos et al. In 1994 demonstrated that the hormonal stress responses in the developing fetus start as early as 18 weeks. Now, at the bare minimum, what you need to perceive pain is free nerve endings and a circuitry like the dorsal spinothalamic tract, the thalamus and subcortical connections, and then the cortex. So all of these free nerve endings and spinal cord projections actually mature by 23 weeks of gestational age. Fabrizi looked at about 150 neonates and did an EEG assessment when a heel prick was done. This was about 10 years ago. And clearly their team demonstrated that there's a difference between tactile processing and nociception that develops somewhere between 35 and 36 weeks of gestational age. So a neonate is perfectly capable of feeling pain. And furthermore, the descending inhibitory pathways that serve as a guard against pain are actually very poorly developed in them. So if anything, they will have a lower threshold for pain than, a higher threshold for pain rather than a lower one. The other thing we keep hearing are that kids are resilient, but again, if we just take a step back and think, the oath we made when we became doctors is to not cause any harm. So that's the Hippocratic oath we took. And not treating a child's pain actually is a violation of that, isn't it? If you ask parents, and many of us in the audience will be parents ourselves, after a correct diagnosis, the next highest priority is, will my child be in pain? So pain control is very important to the parents and to the children. And not treating it will potentially have huge public health implications. And such kids, if they end up with chronic pain situations, will become an economic and social liability to society moving forwards. Again, if the pain is strong, the pain relief needs to be strong too. So I think now it's pretty clear that opioids have been in use right from neonates up to older kids for a long, long time. They are time tested, they are safe. So what we say is, strong pain needs a strong pain plan. And definitely the fear of addiction is hugely overrated. In an acute pain setting, addiction is not an issue, and the consequences of untreated pain are far worse than the theoretical risk of addiction. How we go about measuring pain obviously varies according to the age and according to the situation. So it is essentially a triangulation of what the child is telling us, how the child is, when we look at them, what they are doing, and also how the child's body, so the physiological parameters, and how they are reacting. There is no one size fits all in pediatrics, as we well know. So in very small babies, what we use, there are multiple pain scales. So what that tells us is that there is no one perfect way of doing it. And that's naturally going to be the case with pain, because there is both a emotional component to pain and a somatic component. So it is harder to have objectivity in pain. But that said, a FLAC score is what we typically use in infants in our institute also. FLAC stands for face, legs, activity, cry, and consolability. So a child that is normal, looking quite relaxed, lying quietly, not crying, and easily pacifiable will not trigger any points on this score. Okay, so the scoring is between 0 to 2, so it gives us a maximum score of 10. Anything more than 4 is moderate pain. Anything more than 7 is severe pain. And if you look at the rightmost column in that table, it will be clear to you. And if you just visualize a child who is clenching their jaw, legs drawn up, which is often a very good sign when they're in pain. The kids typically tend to draw their legs up. They're either arched backwards or rigid, crying all the time and difficult to console. We know that such such babies are in pain. In toddlers, we could use the Wong-Baker scale, which is the faces and the smiley faces, and ask the child or look at the child and see where they belong along this path. It could be a 5-point scale or a 10-point scale. Again, our idea is that no kid should trigger more than 2 in a 5-point scale or 4 in a 10-point scale. Older school-going kids, we can use the numerical rating system, pretty similar to adults, and ask them to point where they are in that ladder between 1 and 10. Again, 7 and above is severe, 4 to 6 is moderate. The general principles of pediatric pain management are that pain is deeply personal, and it therefore needs a personalized pain plan. There is no one size fits all, and you cannot just have a cookie cutter approach towards pediatric pain. Children being children, we have to be very careful and precise with our calculation of our analgesic drugs. We have to take into account their weight always, and also their physiological development and comorbidities. All of us know that preventing pain from happening in the first instance is much better than having to treat a child that is in agony. Again, most children's hospitals now are moving away from intramuscular injections. No child would ever want to have an intramuscular injection. So in fact, IM-free zones is now the buzzword in children's hospitals. So wherever possible, we should try our best to avoid intramuscular injections. And like in adults, a multimodal analgesia should be the cornerstone of our therapy. Before going into each drug and its pharmacology, this is something that I felt will be useful to think about as an approach towards pediatric pain. I'm myself guilty of doing a lot of these things, although I now make a conscious effort not to, and I urge all of us to think about whether we are also unknowingly falling into this trap. Lying to the child is never a good idea. The children are quite smart and can understand a lot more than we realize or recognize. making fun of them and saying things like, oh, only babies cry, or you're a big boy and big boys don't cry. Such things actually trivialize their pain experience, and it's definitely not useful in managing the pain situation. The other thing a lot of us are guilty of is using needles as a threat to say that if you're not saying, I'm going to give you an injection, as if that is somehow going to make things better. All that is going to do is wind the child up furthermore. So that again is something we should try our best to resist. Also, giving too high an expectation, giving too high a reassurance both to the child and to the parent can be a problem. Our idea should be to try and contain pain as best we can rather than over-promising. Equally, expecting too much of a child, because this child is already in an unfamiliar environment and is feeling a bit miserable to begin with, having too high an expectation of them to tolerate pain is also probably not very helpful in the grand scheme of things. That said, what is it that we can do to help the child to cope with their pain? Having a parent around often helps in the post-operative room or even preoperative phase. If you're trying to do an intravenous induction, having somebody the child trusts around them helps. Giving simple and accurate information to the child is also a good idea of what to expect, what the surgery is likely to involve. Kids at age 8 or 9 are actually much smarter than we realize. So giving them some honest, active, and accurate information, I find really helps. Giving the child also some control about, for instance, not just in pain, but this is across the board. For instance, between a gas induction or a intravenous induction, you give the child some choice, some control, and often they react to us much better when we do that. And one of the reasons we all like pediatric anesthesia is it's a chance for us to keep the child in us alive and use the opportunity. Play therapy works very well. Play specialists help a lot. And it's a good chance for us to also be silly and play around with the kid. Final thing is also, anything good that the child is doing in terms of coping, positive reaffirmations to tell them that they're doing well often goes a long way in encouraging them to, seek pain relief and also accept pain relief. We are all very familiar with the WHO pain ladder. What we suggest is that it should be orally as far as possible, by the clock, which is something many of us don't do very well in pediatric practice, and also use the ladder. So by mouth, by the clock, and by the ladder. So mild pain, paracetamol and non-steroidals should suffice. Most post-operative cases, which is what the crux of my talk is around, will have at least moderate or severe pain. So they will need paracetamol and non-steroidals, but along with that, local anesthetics, and when the pain is severe or the expected pain is severe, opioids definitely help. We all realize the value and importance of preemptive analgesia, both in adult and pediatric practice. So how we could incorporate it in our practice is to think about putting EMLA or Amitop, the eutectic mixture of local anesthetics, or Amitop cream about 45 minutes before any painful cannulations. At the end of the surgery, encourage our surgeons to put in local anesthetic. So for the postgraduates, especially if you're using 0.25%, the easy way to remember it is 0.8 ml per kg is what the child can have. And this equates to 2 milligrams per kilo of bupivacaine. In my practice, whenever I am anticipating significant postoperative pain, be it a laparotomy, be it hypospadias or a pyeloplasty, pediatric urology, that sort of work, I put in 30 mics per kilogram of caudal preservative-free morphine. Initially used to use clonidine, like I'm sure many of us use, but what we noticed with our surgeons started noticing rebound bleeding and possibly due to rebound hypertension. So about 3 to 4 years ago, I switched over to 30 mics per kilo of morphine, and I find that it works extremely well and really decreases the requirement of postoperative analgesia to just 6-hourly paracetamol and nothing else, even for the big laparotomies and the pull-throughs. The other thing we can do is, of course, peripheral nerve blocks. And in pediatrics, these are traditionally always done after the induction of general anesthesia with ultrasound guidance wherever possible. Now coming to the drugs themselves, the paracetamol, because it's so ubiquitous and so easily available, we often forget how effective it is. It is quite underrated, I think, mainly because we don't give enough of it and we don't give it often enough. So in the older child, the dose, as we know, is 15 milligrams per kilo intravenous every 6 hours, or orally also. You're trying to aim for a maximum of 60 milligrams per kilo per day. In small babies, and in according, again, there is a bit of discrepancy between the various associations in what they recommend, but general rule of thumb is under the 10 kilos, 7.5 mg per kg every 6 hourly seems a reasonable option. So you're essentially giving half what you would give in an older child, because the hepatic mechanisms, the conjugation is not as well developed in an infant as it is in an older child. The idea again is to give paracetamol by the clock. We don't wait for the child to howl in pain before giving it. We are aiming essentially for plasma concentrations of somewhere between 10 and 20 micrograms per ml, which is the analgesic dose really. Rectal paracetamol is probably not that effective because its bioavailability is really only around 50%, and it's no more useful than oral paracetamol. So in my practice, I either give it intravenously or a paracetamol syrup rather than rectal. Non-steroidals, again, are very useful in our armamentarium for postoperative pain. The most commonly studied and used is ibuprofen. In our practice, I give 5 milligrams per kilo every 8 hours and sometimes every 6 hours. And it is the one drug that is actually licensed for use over the age of 6 months. Most pediatric anesthetists feel comfortable using non-steroidals beyond 6 months. Some wait for about a year before using it. Again, caution in cases with renal impairment. The other drug we often use is diclofenac, and that is 1 milligram per kilo every 8 hours. So maximum of 3 milligrams per kilo per day. When given rectally, diclofenac is extremely effective. It's as effective as intravenous almost. And it's a very good way of giving pain relief as a suppository towards the end of the case. Either of them that we use, we can actually reduce opioid consumption by as much as 30%. So please remember to use paracetamol and non-steroidals in every case that we can. Again, opioids have had a bad press in pediatrics, but the fact remains that morphine is time-tested. It is still the go-to drug and still the gold standard when it comes to analgesia, and it's no different in children. So the analgesic dose, effective analgesic dose, is something like 100 micrograms per kilo. Between 3 and 4 hours is the duration of action. So if we feel uncomfortable going to that high a dose, we could start with something like 50 micrograms per kilo, which is what I normally do. And if the child were to wake up in more pain, I give another 25 mics per kilo in the recovery area or just as the child is waking up. If you were to use it postoperatively as Oromorph, we need to remember that oral morphine has only a 0.5 bioavailability. So you will have to give double what you would have given intravenously. Patient-controlled analgesia, for those who may not be very familiar with this, what it is basically a syringe loaded with morphine or a morphine-like drug, and a button is given to the patient to press. Each time the patient is in pain, they press a button and a small amount of the painkiller goes in. What we are trying to do is put the child in charge of how much pain relief they need. So this is very effective. I've found that typically 8 and above, 8 years and above, children are quite smart, and if they have been primed properly in the preoperative visit, this can be an extremely effective way of giving analgesia in them. They need to be old enough to understand, that they are in pain and they're able to process that information. They should also understand that pressing the button will result in pain relief. So any kid who's capable of understanding this, PCA is an excellent option in pediatrics too. PCAs by definition are a bolus-based technique. So they put the patient in charge of how much pain relief they need. So the idea is not to run too much of a background, but to keep it as a bolus-based technique. You could use fentanyl, but the typical initial settings is of morphine for PCA, and those who are intolerant to morphine, you can consider using fentanyl. And again, especially for the postgraduates, please remember fentanyl is something between 50 and 100 times more potent than morphine. So if people are getting scared to use morphine because it's potent, we should be more scared, not less, if we are using fentanyl. Again, an important concept in PCA to remember is that all we are trying to do is maintain the child with for a score, numerical rating score of less than 4. So trying to aim for absolute pain relief may not be realistic after major surgery, but the idea is to help the child manage their pain much better. So our goal really is to keep VAS less than 4. This is a typical recipe that is time tested, and I have now used it even in our setup here and when I was working elsewhere as well. This has been in vogue for a long time. So the idea is to put 1 milligram per kilo. So let's say a 20 kilo kit, you would put 20 milligrams of morphine in 50 ml of saline, of 5% dextrose or saline for that matter. So that will give a concentration of 20 micrograms per kilo per mil. So say 20 mg, if you put in 50 ml, that's 400 mics. So for a 20 kilo kit, that's 20 micrograms per kilo. So our typical settings are just running 0.2 ml per hour as a background. Remember, this is not a background-based technique. So this equates to about 4 micrograms per kilo per hour as a background. That's mainly to keep the line patent more than anything else. Bolus of 1 ml. So each time the kid presses the button, they get 20 mics per kilo of morphine. And you could keep a lockout anywhere between 10 and 15 minutes. So even if the child were to press accidentally twice, they will not get double dosed. When you set up a morphine PCA prescription, please also write up 2 antiemetics, ondansetron at 0.1 mg per kg every up to 8 hourly, and dexamethasone at 0.15 mg per kilogram up to 8 hourly, because almost 1 in 4 children can throw up and have nausea, vomiting after a PCA. The other important prescription we write is naloxone, again in 2 doses, 1 dose for respiratory depression, which is 4 micrograms per kilogram, and the other for itching or urinary retention, which is a much smaller dose. It's 0.5 micrograms per kilo. So both of these also should be in our prescription chart so that the nurses don't waste time having to contact anybody should there be either itching, retention, or respiratory depression. It is very important, at least in the first 24 hours, to keep monitoring saturations and also regular nursing observations. PCA, by definition, is an excellent technique, but like with anything, it does have its limitations. Some of it might be things like the child being unable to understand it, because often those of us who do peds regularly know that children tend to kind of regress when they get admitted and they're in hospital-based surroundings. A 10-year-old typically starts behaving like a 7 or 8-year-old, and an 8-year-old like a 5 or 6-year-old. So that is something that might be a limitation. PCA by proxy is something we need to be careful of. That is what this means, is someone else is pressing the button instead of the child. PCA is patient-controlled analgesia, not parent-controlled analgesia. So what we have to be careful is to tell the parents that the child is the only one who should be pressing the button, and however well-meaning, they should not be pressing. If they feel analgesia is not good enough, they need to contact the nurses rather than taking the matter into their own hands, as it were. Other things that can happen are respiratory depression, but again, if we monitor it properly, it is not usually a problem. Of course, you have to be careful in obese children and those with obstructive sleep apnea. Programming errors, like anything, it's only a machine. It will do what we ask of it. So when we are prescribing it, please take care that you're setting it up. So what we have is a typical regimen. So the ml an hour and everything will be already fixed. So all you need to put is the concentration. That's the only thing that changes between children as a default setting. But when mistakes happen in pediatrics, this is not just for PCAs, errors tend to be 10-fold. So we either give 10 times as much or 1/10. So please be careful about that. The other thing that can happen is pump failure, things like batteries. This may appear simple stuff, but often this ends up happening in the middle of the night, and then the child is left with no pain relief. So please make sure the batteries work and it's plugged in and those kind of things. An acute pain service is always a great idea, and they should be regularly reviewing any kid who is on a PCA, or in fact, any kid who is in postoperative pain. This is ideally led by the anesthesiologist who anesthetizes the case, but at the very least, it should be an experienced pediatric pain nurse. What about those kids who are too young to understand PCA? Another very good option in them is a nurse-controlled analgesia. So the doses are the same, the settings are, the concentration is exactly the same we would use in a PCA. But remember, this is more of a background-based technique. This is purely because of logistical reasons. You can't have a nurse sitting there 24/7 by the bedside. So what we try to do is run 0.5 ml an hour rather than the 0.2 that we were running in a PCA. So this equates to about 10 micrograms per kilo per hour as a background. The occasional bolus, and which is again 1 ml, which is 20 mics per kilo, and we keep a longer lockout because we are giving more of a background in this. So this again is an excellent option. Now, I understand many of us are worried whether this is safe, but believe me, it is. This is a time-tested technique. Richard Howard and others who I had the privilege of training under and then working with at Great Ormond Street published a paper in Pediatric Anesthesia in 2010 where they documented over 10,000 patients who had NCA, infants and neonates essentially, who had NCA between 1996 and 2008. So this is old hat, this is 25-year-old technique. And in that, what they found is 98% of the patients, the parents, were extremely happy. They rated it as either good or very good or excellent, basically. So only 2% we would say would be a failure rate as such. When it comes to adverse events, the serious adverse events rates were only about 0.4%. So that's less than 1 in 200 children had a problem. No deaths whatsoever were reported, but definitely the SAEs were more in neonates, 5 times as much as in older children. So that is something to be careful of. But again, neonates will traditionally be in an NICU sort of setup in our system where the nursing ratios should be good. So certainly, being a neonate is not a disqualification for an NCA, but we definitely need to keep a closer eye on them. Side effects with either PCA or NCA, 1 in 4 children, like I said, could have nausea, vomiting. About 1 in 10 could have itching, and about 1 in 5 could have sedation or respiratory depression. None of these are insurmountable. It's just that like any other drug, it has side effects. And as long as we can anticipate and deal with it quickly, it should not be a problem. Finally, for those of us who are in more senior positions and running departments or are consultants in departments and are interested to see how we can improve our acute pain management in young children, these are some of the suggestions that we can think of. First thing to do would be to audit how we are doing, what our baseline is. We can choose about 3 or 4 common surgeries, have a look at how our children are doing afterwards. It may be that they're doing well, but it may well be that they are not as comfortable as we think they are in the postoperative period. One of the things we need to keep reinforcing is pain is a 5th vital sign. We are very good at documenting the other 4, but most people forget about pain. So if we start educating our nurses and our junior doctors about the importance of pain and what consequences untreated pain can have, that often really helps. Developing an acute pain service is again a very good idea. In our hospital for the last 4 years, we have been running an acute pain service, which is largely physician-led, but definitely a huge role where a pain nurse plays. They see the patients between 2 and 3 times a day minimum, and at least one physician-led rounds happens every day. So once we develop that, people get sensitized to the idea that something can be done about pain, and often the referrals start flowing in much more within a few months of setting this up. An escalation matrix is a great idea because whoever has anesthetized often has no idea what is going on. So if they know who to contact, we are in a better position to guide postoperative therapy in conjunction with the surgeons, of course. Other thing we can do is look at the European Society of Pain Anesthesia's pain management ladder. They have come up with a very nice pain ladder for 6 commonly performed pediatric operations. So we could look at doing quality improvement projects by first assessing where we stand in our current management and trying to get onto that ladder 1 step at a time. Finally, the important thing I feel is that this is not a matter, pediatric pain management is not about fancy drugs. It's even less so about fancy drug delivery systems. What it is about education, about all of us understanding the importance of managing pain well and the fact that it can be done. And once that education becomes part of the culture of the organization, I think we will see significant improvements in pediatric pain management. With that, I come to the end of the talk. I thank you all for your patient hearing. I'd be happy to take any questions. Thank you.